So welcome to Pomegranate Health. I'm Mick Cavazzini, and with me here today is Paul Hotton. Paul, can you give us your elevator pitch CV?
Yep, so I'm Dr. Paul Hotton. So I am a community child health paediatrician at the Children's Hospital in Randwick. I'm also the chair of the chapter of community child health at the College of Physicians.
Okay, so you reviewed my last episode on the National Guideline for the Assessment and Diagnosis of Autism Spectrum Disorders in Australia. It was developed by the Autism CRC, which was at the time a federally funded cooperative research centre. And you confirmed what I was beginning to suspect, that it's not just clinical practice that needs to change. There's a whole system around that that's sometimes in the way.
Yeah, I guess the guidelines are guidelines, so they're really good. But the problem is you've got lots of systems around guidelines that need to be addressed or managed to actually make the guidelines implementable in a way. Systems around access to intervention, access to paediatricians, developmental services. People are aware of the guidelines, but it hasn't actually changed clinical practice, despite it being in for the last 3 years. I know lots of paediatricians that know about the guidelines, but it actually hasn't influenced them what they're doing. They're still referring in for multiple different reasons. And then I guess the whole concept of the guideline is you're picking one neurodevelopmental condition. And we know with autism as alone, there's a whole range of comorbidities and presentations of how they present. So it's quite a complicated system for people to understand.
Mm-hmm. And let's just recap and simplify what I learned about this diagnostic triage. There are florid textbook cases of autism that a paediatrician could diagnose right away. And James Best even joked to me that the receptionist at his general practice would be able to make that call. But those presentations are the minority. Most times the paediatrician needs reports from the school, the family, from allied health to put together a more complete picture. That's what the national guideline we spoke about is really trying to emphasise. And you say that that's what most paediatricians are doing anyway.
Yeah, I think the guidelines just highlighted what probably people were doing anyway. There's just formalised the guidelines. So we talk about classic autism or severe end of autism where they're on their tiptoes, flapping, no eye contact. Most people can diagnose that, but actually autism, that's like the tip of the iceberg of autism as a whole. There's a whole range of children and how they present because the range of the spectrum, there's loads of influences, language, development, intellect, ADHD, language, all of those aspects influence where the child is on the spectrum. So a child presenting to a paediatrician would see the child, get a history, spend time with the child within their time frame of the clinic that they've got. They may have to bring them back for more reviews, but in that meantime, they're trying to access reports from speech pathologists, OT, psychologists, childcare, school, wherever the child interacts. It's not just coming from the parent's perspective. Then they're to put it together, give a diagnosis, or they decide that actually they can't make the diagnosis and they need a diagnostic service to help with that formulation.
And even within that sort of more classic part of the spectrum, there are systematic hurdles. I think you said in your email that paediatricians can't refer to a speech pathologist.
Yeah, so there's a different question to where the child is and the age that they're presenting to a paediatrician. Mm-hmm. So anyone under the age of 7 doesn't actually need a diagnosis. They just need to have areas of concern and areas that they're struggling with, from language, fine motor skills, gross motor skills. Behaviour can add into it, but it's not specifically meant to be about behaviour. All of those things, and they're supposed to be able to access NDIS without a diagnosis. Eventually, they will need a diagnosis for that intervention to continue, but they need a disability diagnosis ongoing. Children under 6 still have to go through that process of whichever agency holds that link to NDIS. They still have to then deem that that child has got a need for intervention. So I think under 6s, you're still trying to can put them onto the wait list for those services to see the child, do an assessment, come up with what they think may be causing the difficulties that the child's presenting with. You would imagine if you're seeing someone from a paediatric perspective, I should be able to use Medicare items to help families access intervention that's not necessarily using NDIS, but there's no direct referral to speech pathologists within the Medicare system. You often then have to send families back to their GPs to access Medicare rebatable chronic management plans, so 5 sessions through an allied therapist. And then there's nothing really for the over 6s. So they need a disability diagnosis, and just being worried about autism doesn't get them intervention. So lots of the community health centres that have speech pathologists within public systems are all geared up to the younger age groups, because that's the bulk of the work. And if you open up services, you get longer and longer wait lists. Often people put up specific intake and exit criterias for services.
Yeah, and it's interesting that only the GP has access to some of the funding models. Conversely, James Best was complaining that GPs aren't allowed to refer to a diagnostic team. They have to go to the paediatrician first.
Well, it depends on how diagnostic services are set up, and that's the thing. So diagnostic services that provide sort of multidisciplinary face-to-face assessment, so the child meets multiple team members in the assessment, they've ended up over time often being paediatrician-only referrals because of their wait times, whereas some diagnostic services will still accept GP referrals as well. So that there's variation in those diagnostic services, and as wait times increase, a lot of the services that see GP referrals as well will end up having to say no because the wait time for everyone else is getting longer. Okay. So the easier way to shut things down. And I think that becomes an equity issue as well then for families who can't afford a paediatrician, who can't afford to keep seeing the GP. And GPs, especially in New South Wales, have started to put a cost and not use bulk bill. That becomes a real cost for families.
Yeah. So going back to the paediatrician collecting all these reports, is there a big difference between conferring with your colleagues to come up with the diagnosis together as opposed to the paediatrician absorbing all that information and making the call?
What was set up as a gold standard for autism assessment was a multidisciplinary team assessment. A multi-disc means I've got myself as a paediatrician looking from a medical perspective. I may have a clinical psychologist that's looking from specifically autism. I may have a speech pathologist in there that's looking at language. We don't all have to also be in the same room. We could all just individually assess the child, and then we bring together our concept to make a decision about the child, what their fundamental difficulties may potentially be in a sort of, do they meet a DSM-5 criteria for autism? Is language the more common thing with development questions? The single paediatrician diagnosis at the CRC guidelines, that is still multi-disc because you're still supposed to use the speech pathologist, the school report, but you then pull it all together. That is quite time consuming for single clinicians, paediatricians that are working in public or private practice as a single clinician. That takes a lot of phone calls, a lot of chasing up reports that may not be available. Everyone working part-time, so you've got to speak to someone when they're not working, you're not working. It's much easier than a single face-to-face assessment to see a child and then pull everything all together straight in one assessment. Okay, yeah.
So the fact that the default option for many paediatricians seems to be just referring on to the full multidisciplinary service, there are different answers as to why this is the case. I mean, you've alluded to one that's it's so time-consuming. It's there's an efficiency of scale, I suppose, of doing it all at once. Is there also a lack of clinical confidence amongst paediatricians? Is there pressure from the NDIS and other disability services to have that team diagnosis, or D, all of the above?
I think it's possibly all the above. Definitely from a training perspective, I think many new paediatricians, whether they're general paediatricians, whether they're going into public or private practice, probably don't feel as skilled up from a training perspective. So most of them have only done potentially 6 months as a minimum of what we call behavioural and paediatric training within the college, which they may have actually not done any developmental assessments as part of that 6-month period. So a lot of private work now we know is predominantly up to 70% of their time is developmental and behavioural difficulties in children across their lifespan, including mental health things. So I think as you gain more experience in managing children and seeing different presentations, your confidence, of course, increases over time. So you become more confident later on versus when you're new. So you're always going to refer in. I also think because wait times, most diagnostic services have got wait times up to 2 years. If you see someone at the first appointment as a single clinician, of course, I'm going to refer into a diagnostic service anyway, because if I see them in 6 months' time to pull it all together,
start the clock then.
You might as well start this clock earlier. But of course, then you're going to be, well, they're on a wait list for a diagnostic service. They're getting intervention. Let's just the child wait.
Yeah, and what you've said about the developmental presentations make up about 70% of referrals. I heard that from a paediatrics registrar as well. And she's told me that some of her colleagues are choosing to upskill in the use of ASD's diagnostic instruments like the ADOS. Is that an appropriate avenue for professional development, or should it come earlier in the training?
I think it depends on where you're going to go as a general paediatrician. Most of our trainees are dual training in general paediatrics and community child health, which is a lot of the focus is around developmental behavioural issues. I think, so if you're going to then go into private practice, upskilling in different tools that you can use, what are the tools out there, how do I do surveillance, do I need to do different developmental screening tools in my clinic, do I need to give families questionnaires to fill in? You may have to upskill in those. I mean, even as a community child health paediatrician, I didn't do my ADOS until I was practicing, because I had the skills. It's just it's still a tool. You still got to then use it to put it to the DSM-5 criteria. Because often I use ADOS is when the case is a little bit more not clear cut, and you really want a tool that can help with that understanding of their social communication impact, which is what the ADOS does. But even an ADOS, that's a lot of time. If you're going to do it in private practice, that assessment can take up to an hour, 2 hours. It's much harder to do it in private practice because to be really accurate in it, you have to often be research trained in it, which is further training in it. As a single clinician, that's then hard.
Interesting, yeah.
So I think from a college perspective, there are ways, even with the CRC guidelines, a lot of it needs to come down to what is available for clinicians to use as single clinicians to help with their diagnosis and their formulation. What is out there for different things to be used? How do we train the next generation of paediatricians to be aware of those tools, what they mean, how to interpret them? There's a bit of work potentially to do.
Mm-hmm. In the last episode, I referred to an article from 2020 referring to wait times of 2 to 10 months for a paediatric consult at Royal Children's Hospital where you work, and just as long again for developmental services. How much worse has the backlog gotten since the pandemic?
A lot worse. There's a significant increase in waiting times. I think having worked at the Children's Hospital in Randwick, where we've tried different models of care to reduce wait times. We've been part of different quality improvements to help families see a paediatrician earlier. We've done that, but our wait times are still increased, and they're up to sort of 14 months to sort of 15 months now for an assessment. I don't know if that's population growth, more awareness of the diagnosis, more clinicians referring in. It's actually hard to know. I definitely know there's more referrals than we can actually see as children based on how the services are set up. We've had position statements, we've even from governments looking at early intervention, screening children early. The problem with all screening stuff is it's all well and good to screen, but where are you actually going to send them? So if you're screening and you're identifying more, where are you sending those children? You've identified more of them. And the challenge of most then services, even from a multi-disc, so the second tier for the CRC guidelines, is those services haven't had further increases for 20 years. So their structures are based on the population 20 years ago and haven't had increased funding into those services, especially in New South Wales.
Yeah, you can't just change one tile. And we've sort of touched on reimbursement. I spoke to a school psychologist counsellor in Newcastle, Scott Gould, who said that in trying to get a referral accepted by a local paediatrician, they were told that the books were full, closed to developmental cases, and his impression was that the paediatrician didn't want to take on all that administrative burden because it was hard to get reimbursement for it. This is reflected in the comments that the RACP made to the Senate Select Committee report on services, support and life outcomes for autistic Australians, published in March last year. I can quote something from there if you can tell me if it rings true. The second recommendation from the RACP submission notes that there exists only one MBS item number 135 for an ASD-related consult, and that doesn't do justice to all the complexity. Quote, the RACP recommends introducing an annual MBS item number that would allow for an hour-long review of patients' goals and needs. 2, introducing a standalone item number for transition to adult services. And 3, allowing item numbers that exist for people with intellectual disability to be extended to adults with ASD. And Professor Valse-Appen and colleagues have also called for Medicare funding for group telehealth consults to bring together different specialties. Does any of that?
Yeah, within even the 135, which was the better access to autism, that was called the HACWA funding, is actually gone as an item number as well. So the part of NDIS has removed that as an item number, so it's even harder for people to access that number, and often it only gave you 20 sessions in your life course up to the age of 14. You can bill at that number, but you can only bill once with one paediatrician. So they hold that number, and only there you can refer then on to other services. You have to have the specific name of the therapist, and you write to them to help access for that. That was that item number. What most paediatricians have to do is there's 2 item numbers. You get a new referral, which is a 132. It's 45 minutes or even less than that. It might be even 20 minutes. But you have to have, the GP then has to refer, and they have to have a specific quote now to access that item number. Most paediatricians will only bill as a 110, which is one issue. So if you've got a child who's got sleep issues plus developmental issues, that's 2 issues that you're trying to address in such a short time. So the item numbers really isn't reflecting anymore what paediatricians are doing, especially as we move into a mental health space and looking after children with mental health. We're creating management plans, diagnostic, linking up to schools, therapists, trying to sort of care for the whole child as a whole through their life course and the family. The items don't reflect that work. So if I was a paediatrician in private practice, I can't bulk bill because I can't run my service on the amount I get from a Medicare item number. You're going to charge families, which then has further inequities for families that can't afford paediatricians. And so I think there needs to be a greater work looking at the Medicare items now. What does it reflect now that it did years ago?
And so again, that's another sensible, pragmatic reason why paediatricians are just referring on to...
Why paediatricians refer on to multi-disc services, because of the amount of work that then they're not billing for that. But also, yes, paediatricians are probably closing books because the amount of work they're having to do, they just can't keep up with the demand. Most paediatricians, some work full-time, but we have a predominantly female workforce, which is amazing for pediatrics, but also from everyone's perspective in life, working part-time is beneficial from life to work balance.
Of course, yeah.
And so, if you're working 3 days a week, getting paid 3 days a week, but you're having to spend the other 2 days away from your family to do paperwork, chase everything, it's not a work balance. So people will start closing books because they've got to keep their the balance of what they're doing down and manageable.
And provide quality of care to the patients they do have on the books. Let's touch on the idea of surveillance. According to an audit published in the MJ in 2015 by researchers from Trobe University, the average age of diagnosis in Australia is 4. Now, those data are about a decade old, but they were incorporated into a meta-analysis that found diagnoses came significantly earlier in Israel, the UK, and a bunch of European countries. What do you make of that comparison?
I think probably in European countries, having come from the UK, I think surveillance of children is much greater, with the systems quite different here in Australia from a public health perspective to a private enterprise. I think the diagnosis probably here is later because we probably have longer wait times potentially that influence that as well. And so that combination of things impacts that. Most children with autism actually need a period of time of surveillance, which probably doesn't help families, but sometimes you see a child at the age of 2 and you're not quite sure. They've got developmental issues. They may have autism because it's such a spectrum. They may not. You need time to get intervention to see what happens to that child. Likewise, you could be completely at 4 years of age saying this child's definitely not autistic, doesn't meet the spectrum. But as they get to school, the social demands of school means that they start to struggle much more about the social communication aspects, and some of the subtle things that they had about restrictive and repetitive behaviour, which you didn't quite notice when they were younger, is more apparent as they're getting to school because the demands are greater for them. Social demand is so much great, they've got more anxiety, so the behaviours are more present. So it's actually really difficult to know. Surveillance would probably be better for most children. So you see them, get them intervention, you just follow them up over time. The difficulty is I'm not sure that is actually from a parent perspective or a carer perspective helpful for them.
Well, I mean, the idea of broad surveillance, developmental surveillance, it is in the Blue Book, it is in this national guideline, but to have good surveillance you need continuity of care, and I wonder if in Europe, so my aunt is a paediatrician in Italy, a child until they're 6 years old only sees a paediatrician. They're assigned to the local paediatric service. In the UK, it's the GP, but you have a medical home. You can't go outside that catchment, and that's true of adults as well. I wonder if in Australia, where we have a more sort of privatised, shop-around approach to primary care, it's harder to get good surveillance from the same clinician who's going to recognise changes in that kid.
Completely, and even the American system has got all children then just follow up with that paediatrician like they would a GP in a way. Watch Me Grow is now the new sort of surveillance tool for families to use. There's different apps for them. But I think if you had a regular clinician that you were seeing, someone that you could regularly ask things, see things, it'd be different. What we should be utilising is that primary healthcare network that we do have. So GPs, child and family nurses who are skilled in doing surveillance and screening. And we should be pushing for that surveillance to happen at the time points from the Blue Book.
I apologise if some of this comes across as New South Wales-centric. I believe that Western Australia has a purple book, Queensland a red book, and Victoria a green one. There are many important differences between the state health services, but I want to share some insights from Associate Professor Josephine Barbaro at Trobe Uni in Melbourne. She's a Principal Research Fellow at the Olga Tennison Autism Research Centre, and a clinical psychologist who has been pioneering early assessment of ASD. Josephine Barbaro told me that Victoria does come close to the Italian model I was talking about earlier. In that state, children are monitored to the age of 3.5 by a paediatric practice, and then after that they stay with a nominated child and family health service. When it's not possible to see the very same specialist or nurse, at least the medical records are shared. Associate Professor Barbaro is not convinced that Australia is lagging behind other countries when it comes to detecting autism spectrum disorder in the community. It was her team that produced that figure of 4 years as the average age of diagnosis in this country. But we can't be sure how consistently diagnoses were recorded in those international studies. She reckons that those with the lower ages of detection may be considering only the more profound examples of ASD and missing the hard-to-pick low-level cases from their calculus. It's been a consistent and predictable observation that more severe cases of ASD are diagnosed earlier in childhood. Another confound that came to my mind was the age at which children get exposed to the social stress test of preschool or kindergarten. When it comes to enrolment rates in early education for 3 to 5 year olds, Australia is a few points below the OECD average of 87%. Meanwhile, in countries where early education is universally funded like the UK, Belgium, France and Israel, enrolment rates are over 98%. I'm painting with some broad brushstrokes here, but I hope this highlights how many factors right across the health and education system can influence numbers like age of diagnosis and incidence. Diamond-hard epidemiological data are very hard to come by. Josephine Barbaro and her team used a registry from the Helping Children with Autism scheme, described in the previous interview as HAQUA. This was the predecessor to the NDIS Early Childhood Early Intervention Program, and a key difference between them is that under HAQUA, children up to the age of 7 did require a diagnosis of ASD or pervasive developmental delay in order to receive funding, which would then carry on till the age of 13. As a result, the registry data showed an apparent spike in incidence of ASD just before the age of 6. In fact, that was the most common age of diagnosis, but not because of any environmental factor that was causing more kids to develop autism at that age. It's just that clinicians were making sure their patients would get HAQUA support before the window for eligibility would close. As I've already said, numbers alone don't tell the full story. Josephine Barbaro, with colleagues Kathy Bent and Professor Cheryl Desanayake, also conducted a qualitative investigation subtitled "What Predicts an Early Autism Diagnosis in Australia?" They recruited families from the HACWA registry over 2014 and 2015, of which 136 completed a survey about their healthcare journey. The results were pooled depending on whether the diagnosis came below or above the age of 7, and there was considerable divergence in the experiences reported by the two cohorts. Kids who were diagnosed early had first presented to health professionals around the age of 2.5, and it took a year on average to receive a diagnosis. For the older cohort, concerns had typically been raised around the age of 4, but it took on average 4 years and 10 months to receive a diagnosis. While these older kids were likely those with less profound presentations, it doesn't sound like there was a great deal of follow-up taking place. 39% of respondents had been told not to worry by clinicians, and another third to wait and see. The average number of consults to diagnosis was 8, and only half the families noted that a developmental assessment had been conducted within the first 3 of those. It would be interesting to know how clinical practice has changed since the switch in 2016 to the NDIS funding model. Hopefully there has been less wait and see and a bit more early intervention. We can't actually make an apples-to-apples comparison because the Medicare item numbers that the HACWA registry was based on are now obsolete. And we may have actually swapped one bureaucratic driver of practice for another. You see, the remit of the NDIS is described as providing support for people with, quote, permanent and significant disability that helps them increase their, quote, social and economic participation. Within this framing, it's considered that only ASD levels 2 and 3 are profound enough to warrant government funding for children over the age of 7. Children with ASD level 1 might make the cut if evidence can be provided of significant needs in other domains, but it takes a lot of work to get those reports, and you're not guaranteed a result. I'd heard that clinicians were now tending to be a bit liberal with level 2 diagnoses, so I asked Paul Hotton for his thoughts.
Yeah, and even as a clinician, I probably do that sometimes as well. I think because autism is a spectrum, it fluctuates on a day-to-day basis, and these levels are arbitrary levels.
Yeah, of course.
So, of course, you're going to adjust them. If you really think they need some behavioural support, you're going to adjust the diagnosis. That is what clinicians are likely to do.
Yeah, Professor Yarpin even joked to me that this threshold within the NDIS, quote, has wiped autism level 1 from the face of Australia. Whatever we agree on about this bureaucratic model, it is concerning, isn't it, that clinical decision-making and even epidemiological data are getting distorted by the red tape.
Yeah, and that wasn't how the levels were originally designed in the DSM-5. It was actually about what the function of autism was doing.
Well, in the DSM, it still says level 1 requires support.
Yeah.
That's in the
DSM
manual.
says it's about how much support, and we've made a decision that 1 just needs enough in community health settings. Like, you can use the mental health plan for that. And it's like, well, you can't actually then access the therapist because they all want NDIS potentially, and you've got different wait times, how you can access. The problem with NDIS is it's a yearly, sometimes 2-yearly renewal. That level could have fluctuated in that meantime as well.
Yeah, and if they're sort of palming it off to Medicare, well, it's still Commonwealth funding. Which pot does it
whichever
come
pot you take it from, it's still a pot, but it needs to be support. But the problem, NDIS then doesn't have the families out of pocket, although their money might not cover everything. Whereas in Medicare items, you still have to, there's still a gap that families have to pay. It only gives you a certain proportion back. So they still need levels of support.
I mean, in my friend's case, the kid Jack is quite bright, he's a good reader, but he's really unsettled, ADHD, doesn't like to sit in class, wasn't responding to the speech pathologist that they were getting from early childhood intervention, but he did respond very well to medication for the ADHD. Yep. You could say, well, that's PBS subsidised. Is that enough? Is that is that the Commonwealth supporting the needs of this child? To an extent, yes, but it might be more complex than that, I suppose.
Well, I think that's where people find levels hard to decide on children specifically around autism, because children come with neurodiversity, so predominantly a lot of children with autism have ADHD, and anxiety is the principal conditions that go hand in hand sometimes with it. So that ADHD or anxiety may be influencing the autism, but actually from a level perspective of function of just if you focus on the autism, they may be level 1. But if you add in the ADHD and anxiety, that behaviour is being influenced by something else. So do you give them a level 2 because they actually need more support around it? Do you not?
They might get a mental health care plan for the anxiety. They might get PBS subsidised drugs for the ADHD, but is that enough in the whole picture, or do you need one plan from the NDIS?
And is that right for families to be trying to access from different things, not really understanding what's needed? It becomes a really complicated system for families to understand. And I'm an advocate for NDIS because I think the purpose of it was a really good holistic purpose to access, and you should access intervention based on your severity of need. So rather than everyone get the same lump sum, it's based on a needs assessment, but then there's the fundamental implementation of it for services, how you govern different therapists who charge different prices for different areas. How do we justify, if you live in the east of Sydney,
you get more money to pay.
Do you get more money or less money? Your services may be more expensive, less expensive than the Western area, and we create ongoing equity in division of our state as a whole. I think most families I see struggle once they hit 7 to write plans for themselves, to write really comprehensive plans to get the right funding for their child, despite having sort of local area coordinators that are meant to try to help families deliver that.
You can sort of understand why the bureaucracy is the way it is, but it doesn't make things easy for people who are already in a lot of strife. I do want to clarify one misconception, though. The NDIS does respect a single clinician diagnosis just as much as one from a multidisciplinary team.
Yep.
In fact, it was the administrators of the NDIS who commissioned the Autism CSC to develop the Australian guideline. They were trying to lower the barrier to entry, but perhaps they didn't know what they were in for. If I'm not mistaken, of the 502,000 participants currently enrolled in the NDIS, about 120,000 are living with autism, which is 24%. Does that sound right?
Yeah, that's probably about right. I think probably when people were doing this, they didn't quite work out how much it was really going to cost as a delivery when they brought out NDIS and what was going to happen from growth of a population. I also think there's lots of ways to think about autism. Why has it become more common? Why is it higher here? What's the epigenetics inheritance of autism? Has that played a part? Is there something around living in Australia? It's huge, but I think we're not quite understanding how much there is out there to then how much supports are being able to access for families, and then the funding. An easy way to delineate funding is to say, well, level 1, you only need a little bit of support, so it's not a disability.
I mean, this is all over the news these days. The NDIS as a whole is expected to cost $59 billion a year by 2030. That's twice what it's costing right now and 4 times what had been predicted at its inception a decade ago. So now we hear stories about more delays to access, cuts in funding to recipients who had become reliant on certain supports. I don't have an easy answer for the administrators, but there is also the cost of inaction to consider. So Professor Alpin pointed me to an economic analysis commissioned by Telethon Kids on what they called the cost of late intervention. It showed that the government spends $15 billion a year on crisis services for youth mental health, family violence, homelessness, unemployment, justice, and so on. They didn't mention autism specifically, but even low-level ASD, you could do that analysis.
You can do it with
lost productivity of these kids.
There's a whole heap of research that looks at this in particular of an inverse law. So if you don't put any intervention into children, then they present it with mental health difficulties later on, which costs us more, costs us a burden on further aspects of their health in a way, more disadvantage for them, more difficulty accessing jobs, financial difficulties, social determinants of health. So there's a greater than cost. And the problem is in the health system, we are always about crisis managing. Let's put a Band-Aid on a service. But what you're not doing is the backlog of children that are about to come through. We just keep putting more and more bandage.
You'll pick up the tab later.
And we do it later on. And I think that's difficulty with governments and change of governments, different
3-year cycle.
cycles. You've got different states here, which all of that impacts on then what happens to children's health. If you invest early and you put loads of money into intervention really early on, the long-term benefits will mean that you get your money back.
I mean, I haven't read the 2019 review of the NDIS by David Tune, which had 29 recommendations for making access to the scheme more equitable and decision-making more transparent. But is there anything we haven't touched on specifically around autism that you'd like to throw in?
I think it's... Look, I think the question was the CRC guidelines. I think they are good guidelines. They are good guidelines. It's then about thinking about how you implement those, what needs to be there for it to happen. Because I actually do think single clinicians can actually do a lot of work in that early stage. Not all children need to go to diagnostic services, so you reduce that wait times potentially. But if we're not going to support that single clinician with right Medicare billings, right supports, access to reports, then that guideline's never going to be implemented.
Before I go, I just want to address Paul Hotton's open question of how much autism spectrum disorder is really out there. Josephine Barbaro thinks it could be up to 5% of the population, based on outcomes of a study she and her colleagues have just had published in JAMA. For over a decade, they've been refining an autism screening checklist called the Social Attention and Communication Surveillance Tool, or SACS. The recent paper examined the diagnostic accuracy of a revised format of the SACS, and a preschool-specific tool in a large community-based sample. Over 13,500 Victorian children underwent the screen at least once during routine health visits to a maternal and child health nurse during their second year of life. Positives on the screen were then referred to a clinician for a standard diagnostic assessment, and many negatives came back for follow-up screens up to the age of 4. Sensitivity of the SACS revised was modest in the first iteration, but increased to 96% when the last screen was taken into account too. Prevalence of ASD by preschool age was determined to be 3.3%, but Josephine Barbaro says it would be closer to 5 once all false negatives are considered, and those diagnosed late as adults. The most remarkable finding from the study was the fact that the average age of diagnosis in this community setting was under the age of 2. This is 2 years sooner than what's currently occurring at the population level in Australia. And just as important, not one child flagged positive by the screen was found to be developmentally neurotypical on diagnostic testing. The majority met criteria for autism spectrum disorder, but other syndromes of developmental delay were also detected. With specificity at almost 100%, Josephine Barbaro said this should put to rest fears about widespread use of screening tools for ASD. In the last episode I mentioned how screening had been debated in the drafting of the 2018 National Guideline for Diagnosis of ASD. The RACP had been one of several voices to raise concerns that ASD-specific checklists weren't used consistently, they lacked diagnostic accuracy outside targeted settings, and that the high rate of false positives would cause unwarranted stress to families. A triaged model was adopted instead, whereby non-specific developmental screens were recommended, and these might then lead to a referral for diagnostic testing for autism. Associate Professor Barbaro argues that primary healthcare staff can be quickly taught to administer the SACS. Their expertise means the checklist isn't as easily tripped as others that rely on self-report from families, like the MCHAT, the Brigance, or the BITC. Josephine Barbaro is keen for paediatricians to adopt this as a first-line tool when receiving referrals with developmental concerns, and says it would give them confidence in managing these patients. But to detect cases even before families have concerns, she insists we need to make better use of maternal and child health nurses. We already have community health centres in most regions, but they're underutilised by the public. Josephine Barbaro says that this would be a more impactful strategy than to try and get GPs to squeeze more into their already jam-packed consults. If this advice does get adopted, I suspect it will be at a local or state level before it makes its way to the next national guideline. This podcast, more than most, has reminded me how many moving parts there are to the machinery of healthcare in Australia. Many thanks to Josephine Barbaro and Paul Hotton for their patience answering all my questions about how these fit together. The opinions presented are their own and may not represent the official position of the Royal Australasian College of Physicians. As ever, I'm grateful to the members who gave up their time to review drafts of this podcast. They're named at the website along with all the musical artists you've heard. The address is racp.edu.au/podcast, and you'll find lots more reference material linked there too. If you go to elearning.racp.edu.au, you can browse all the latest online resources developed for you by your peers and the professional practice team. Recent additions are a reading library on medical standards for driving, a self-paced course on supporting Aboriginal and Torres Strait Islander patients through genomic healthcare, and another on quality and safety in rural medicine. And don't forget the massive lecture library called the College Learning Series that's mapped to the training curricula for both adult medicine and paediatrics. I'm Mick Kavatsini, and this podcast was produced on the lands of the Gadigal people of the Eora Nation.
That move, sort of witty and jaded, but let's not talk about you. Your cowardly song.